Welcome back to Chapter 43 this time with Neonatal Care. Chapter 43, it's a two-part chapter, not an overly long chapter, but it does have quite a bit of information in here. This chapter and especially Chapter 44 are essential chapters that you really need to make sure that you know very, very well. Otherwise, it can be detrimental to being able to move forward in the paramedic program. So these are two instrumental chapters. This is the first one of those two chapters, and this is part one of that. So we'll just go ahead and get started with Chapter 43. Newborn care should be tailored to meet the unique needs of each infant. Of course, when we're talking about a newborn, we're referring to an infant in the first few hours after they are born. While a neonate, this is a little confusing, a neonate is an infant during the first month of life. So an infant during the first month of life is a neonate. A newborn is a baby that's in the first few hours after they're born. When a newborn requires some special care and trained professionals, parents oftentimes are going to feel very overwhelmed and very inadequate, stressed out, and you name it, all of those things, they're going to feel those. So it's crucial for us as paramedics to not only provide care to the newborn, but also as much as possible as we can, keeping parents in the loop or their caregivers in the loop of what's going on. So we want to encourage those parents to stay close to the baby as possible to where that we can still work, but they can provide some comfort and reassurance. Make sure to clearly explain the procedures that we're doing and the care that's being provided. Also provide some detailed information about any plans for transporting the baby to another facility if that's going to be necessary. About 1% of deliveries require skilled interventions to support the newborn's heart and lung function. Each year, around 8% of newborns are born weighing less than 5.5 pounds. With prematurity being the primary cause of this low birth weight. As both birth weight and gestational age decreases, the risk of death is going to increase proportionally. Before birth, the fetus receives oxygen through the placenta, bypassing the need for their own lung function. Fetal circulation has three major shunts that are different from adult circulation. They have the ductus venosus, which allows blood to bypass the liver and flow directly to the heart, so it kind of cuts the filter out. Then they have the foramen ovale. This enables the blood to flow between the right and left atria, completely bypassing the lungs. And then the ductus arteriosus connects the pulmonary artery to the aorta. This also bypasses the lungs. It's another route or another way that it bypasses the lungs. As the baby begins to breathe air after birth, these shunts will gradually close off to establish what we know as normal circulation. Of course, this here kind of shows that, a depiction of that. You know, this graph kind of shows how those bypasses and shunts are in place. And then what happens afterwards, after those shunts and everything are kind of closed off. You can see how, you know, the different colored veins, you know, arteries, veins, how they're different colored, you know, associated with oxygen or deoxygenated, low or high oxygenated, and how much that changes once everything shuts off, once those bypass routes are closed off and things turn into a much more normal circulatory system. As the baby is delivered, a vital transformation begins that allows the newborn to start breathing independently. The first breath is usually triggered by a mild oxygen deprivation and the rise in carbon dioxide caused by the partial compression of the umbilical cord during birth. Tactile stimulation and exposure to cooler air further encourage the baby to take that first breath. As the lungs begin to expand with air, the blood vessels within them start to relax, lowering the pulmonary resistance. This decrease in resistance allows more blood to circulate through the lungs, supporting oxygen exchange, and therefore stabilizing the newborn's breathing efforts. However, if the pulmonary pressure remains high, this transition can be delayed. A delayed transition can result in inadequate oxygen levels, which may lead to brain injury or even death. The timing of birth also plays a crucial role in how well this transition goes. Babies born before the 37th week of gestation are considered preterm and are at a much higher risk for complications. Babies born between the 38th and the 42nd week are considered term and generally have more stable transitions. Those born after 42 weeks are post-term and may face a unique set of challenges during this period as well. When the newborn arrives, it's important to gather a patient history and prepare the environment and equipment as effectively and efficiently as possible within the time frame that we have. Some key questions that we want to consider during this time to make a determination for the likelihood of resuscitation or resuscitative equipment is things like the mom's age, the length of the pregnancy, the presence and frequency of contractions, whether there's been any fetal movement, any complications during pregnancy, if the membranes have ruptured, including the timing and makeup of the fluid that's present, whether there are multiple babies, medications maybe that the mom is currently taking. And of course, at minimum, realize you're going to need some warm and dry blankets, a bulb syringe, 2 clamps or ties, and a pair of clean scissors in order to clamp and cut the cord. Complications should be addressed and managed promptly. If the baby is delivered in the ambulance, start by covering the foot of the stretcher with clean, warm blankets for initial stabilization. Once the airway, breathing, and pulse are confirmed to be adequate, place the newborn on the mother's chest for some skin-to-skin contact. If more extensive resuscitation is needed, transfer the newborn to a second ambulance equipped with a neonatal transport incubator if available. Using a bulb syringe, suction the mouth first, followed by the nose, once the head is delivered. After delivery, keep the newborn at the level of the mother, with the head slightly lower than the body to help blood circulation. Clamp the umbilical cord in 2 places and cut between the clamps. If the cord comes out ahead of the newborn, it may cut off the blood supply to the baby. Relieve pressure on the cord by gently moving the baby's body around the cord and gently pushing the cord back into position. A primary survey of the newborn can be performed alongside any necessary treatment interventions. Note the time of delivery, monitor ABCs, and assess the airway, respiratory effort, muscle tone, pulse rate, and color of the baby. Inspect the newborn's skin for any abnormalities. In this case, you're going to check for this kind of a white cheese-like substance that coats the skin of the baby during pregnancy. You're going to look for edema or discoloration, such as Mongolian spots or jaundice. Examine the head for symmetry and abnormalities. Inspect the eyes for irregularities. A newborn who can't open their eyes may have a congenital defect. Look for abnormal eye movements as well. And subconjunctival hemorrhages are common and harmless in newborns. It's part of the birthing process. And check for any drainage or ocular discharge as well. Inspect the umbilical cord for abnormalities and check the abdomen for issues such as abdominal hernias or those types of things. Remember that newborn is at great risk for hypothermia. Ensure that we help them maintain that thermal regulation by placing the newborn on pre-warmed towels or blankets if possible, drying the head and the body thoroughly, and discarding wet towels and replacing them with dry towels that are covering the baby. Cover the head with a cap to retain warmth, and then of course position the newborn to maintain a patent airway. Make sure you clear any secretions and continually assess their respiratory effort. All babies are a bit cyanotic right after they're born. If the newborn remains vigorous and begins to turn pink within the first 5 minutes, simply continue monitoring the baby closely and help them to maintain that thermal regulation. And this is best achieved by skin-to-skin contact with the mother while en route to the hospital. Skin-to-skin contact covered with a blanket will help that baby stay warm. The APGAR score actually helps to assess the newborn's condition in a few minutes, immediately after and a few minutes after birth. It aids in determining the specific resuscitation measures that we may need to take and how effective those measures may be. The APGAR score evaluates 5 categories: appearance, pulse, grimace, activity, muscle tone, and respiratory effort. Each sign is assigned a value of 0, 1, or 2. The score is recorded at 1 minute and 5 minutes after birth. If the 5-minute score is less than 7, an additional score should be taken every 5 minutes until 20 minutes after birth. If resuscitation is required, another APGAR score should be recorded after the resuscitative efforts. These are things that you want to keep in mind. It's actually not a perfect world. If you're resuscitating a newborn, you're not going to have a whole lot of time to jot things down or tally up scores. So these are things that you want to keep in mind and keep a mental picture of as you're going through this process. Initial steps, of course, are reevaluation, and the initiation of ventilation should occur within the first 60 seconds after the baby is born. We're going to start by providing warmth, positioning to get an airway open and keeping the airway clear, drying and stimulating the newborn. These are going to be our first steps. If the newborn doesn't respond, further intervention is going to be required. Assess the respiratory rate, respiratory effort, pulse rate, and color. Count the respirations and the pulse rate for 6 seconds and then multiply by 10 to determine the rate per minute. Many newborns may have acrocyanosis but still appear pink in the centrally, in the core. If the newborn has normal breathing pattern and the pulse rate is greater than 100 beats per minute but exhibits central cyanosis, provide supplemental free flow oxygen. If the newborn remains apneic or has a pulse rate of less than 100 beats per minute after 30 seconds of drying and stimulation, begin positive pressure ventilation using a newborn-sized bag mask device. Be cautious not to squeeze the bag too forcefully to avoid hyperinflating the lungs. Room air is preferred for term infants, and supplemental oxygen may be necessary initially. If the neonate does not reach the target oxygen saturation for their age, additional oxygen may be required to get them up to that point. If the newborn's pulse rate is less than 100 beats per minute, check for visible chest movement. If chest movement is inadequate, take corrective ventilatory action immediately. It may be necessary to insert an endotracheal tube or an LMA, depending upon the situation that you're dealing with. If that pulse rate drops below 60 beats per minute, you're going to need to start chest compressions. Effective chest compressions should produce a palpable pulse. Use a pulse ox during those resuscitative efforts, especially when the newborn appears cyanotic or when chest compressions are needed. If the bradycardia does not improve with ventilations or chest compressions, then you may be able to administer epinephrine, preferably through an IV line or an IO. If IV access can't be contained or cannot be obtained, of course, move on to IO. IO is probably going to be one of the main primary routes on these little newborns. If there are no signs of life after 10 minutes of resuscitation, the likelihood of successful resuscitation is very low. Outcomes are generally associated with a high early mortality rate. This figure, of course, shows the AHA algorithm for neonatal resuscitation. Note the box there on the right-hand side, and that's our target SpO2 levels after birth. So at 1 minute, we would expect those to be low, but within 10 minutes, we would expect those to be up to the normal range. Those should begin to creep up into that normal range. So expect those SpO2 levels to be low initially after birth, and then progress to get better and better at the 5 and 10 minute marks. After making sure the airway is clear, dry and stimulate the newborn to encourage breathing. Position the infant on their back or side with their neck in the slight sniffing position to help maintain an open airway. Use tactile stimulation, such as drying the newborn or gently flicking the soles of their feet to prompt them to breathe if their breathing appears to be ineffective. Consider suctioning the airway if positive pressure ventilation is needed and there are signs of an obstruction. If the newborn appears cyanotic or pale, provide supplemental oxygen using the free flow or blow-by delivery method. If positive pressure ventilation is not needed, oxygen can be given using an oxygen mask or by cupping the oxygen tubing near the newborn's nose and mouth. Set the oxygen flow rate to 5 liters per minute. Be careful not to blow by oxygen directly into the newborn's eyes. I'm going to make sure that we avoid that. Oral airways are rarely used in newborns, but may be necessary in certain conditions. Situations that may require an oral airway include defects that obstruct the airway. In most of these cases, an endotracheal tube is typically inserted through a nostril to maintain the airway. But be aware that if the baby has a condition known as bilateral cranial atresia, this is a condition where the back of the nose is blocked by a bony membrane that's present there, so we wouldn't be able to place an ET tube through the nostrils in those particular conditions. There's also a condition called the Pierre-Robin sequence. This is where there's developmental abnormalities that include a small chin and a tongue that's positioned farther back than normal. Both of these types of conditions that are common with Pierre-Robin can interfere with breathing. This figure here kind of shows what that looks like, that Pierre-Robin sequence. Realize there's some other conditions that may cause a small and recessed mandible. Pierre-Robin is the combination of the recessed mandible and the tongue that's further back in the throat. Bag mask ventilation is indicated when a newborn is apneic and poor respiratory effort or has a low pulse rate below 100 beats per minute after the basic steps have been completed. These steps include clearing the airway of secretions, properly positioning the airway, and drying and stimulating the newborn. Signs of respiratory distress that may suggest the need for bag mask ventilation include periodic breathing, intercostal retractions, nasal flaring, and grunting during exhalation. So these are those signs of respiratory distress that we want to watch out for that may indicate that we may need to provide supplemental ventilations. There are 3 main devices that we're going to use to deliver bag mask ventilation to newborns. There's a self-inflating bag with the oxygen reservoir, there's a flow inflating bag, and a T-piece resuscitator. Always use the infant size bag or the 240 ml bag when it's available. And realize that each breath is only going to use about 1/10 of that bag's volume. If a neonatal bag is not available and an adult or a pediatric bag is all you've got, it can be used, but the breath of the volume must be kept very, very small and just enough to see chest rise. and you have to be really, really careful to avoid overinflation using an oversized bag. When administering bag mask ventilation with 100% oxygen, ensure the face mask forms an airtight seal. The airway must remain open, and the newborn's head should be in the sniffing position. The first few breaths after birth often require higher pressures, sometimes up to 30 millimeters of mercury. After that, use just enough pressure to produce a visible and controlled chest rise. A ventilation rate of 40 to 60 breaths per minute is ideal, as faster rates can lead to complications such as hypocapnia, air trapping, and potentially even a pneumothorax. Continuous positive pressure ventilation, as long as the pulse rate remains below 100 beats per minute or the newborn's breathing effort is absent or weak, is essential. If positive pressure ventilation is needed for more than 1 minute, connect the system to a pressure manometer to monitor the ventilation pressures if that is available. So it's really essential that we don't overpressurize these new lungs, these very young, fragile lungs. Common causes of ineffective BVM include an inadequate mask seal on the face, incorrect head positioning, excessive secretions, pneumothorax, or equipment malfunctions are pretty common cause of that. Intubation is indicated in several specific situations. It should be performed if there's meconium staining fluid present and the newborn is not vigorously responding, as this may indicate in utero hypoxia or stress. Intubation is also recommended for congenital diaphragmatic hernia, which is known if it is known or suspected and respiratory support is required. It may be necessary if prolonged positive pressure ventilation is needed as well. Intubation is also indicated when we have some of those craniofacial abnormalities that prevent us from maintaining a good adequate airway, such as the Robbins condition. The following equipment should be readily available for newborn intubation: suction equipment, laryngoscope, straight blades, shoulder roll, adhesive tape, and of course the proper sized endotracheal tubes, and a stylet. For step-by-step guidance on this, you can look at the skill drill 43.1 in your textbook. It'll give you some guidelines on this. We're going to cover this extensively in the lab, so you're going to have multiple opportunities to practice this using the equipment that's needed. So, really for the context of this is just more informative and informational than it is expecting you to know this when this lecture is over. Sometimes we may need to do some gastric decompression. This happens oftentimes will happen if we have to use a bag mask ventilation for longer than 5 minutes. We'll start to see abdominal distension that is beginning to affect ventilations as well. Or there may be a diaphragmatic hernia or a gastrointestinal congenital abnormality that's causing us to have to do this gastric decompression. Of course, look at the skill drill on 43.2. It'll show you the proper process for doing that decompression correctly. Now, so when it comes to chest compressions, they're always going to be needed anytime the pulse remains below 60 beats per minute. Make sure that you have correct positioning, a clear airway, and that you've tried drying and stimulating. 30 seconds of effective positive pressure ventilation sometimes will get that heart rate up. And of course, if you do have to resort to doing chest compressions, 2 people are going to be required to do chest compressions while still being able to perform ventilations. 2 different techniques that we commonly use. It's the thumb technique and the 2-finger technique. These are routinely taught during AHA classes, so these are not new. The thumb technique is actually preferred because it's more effective, and it's easier to keep the pace up, and it also makes it easier for two-person CPR. It's going to be the preferred method when we have two providers that are doing CPR so that the ventilations are not interrupted. Compression depth should be about 1/3 of the chest, and chest compressions and artificial ventilations cannot be done at the same time on newborns and infants. So we're going to have to pause and allow those ventilations to go in. And this is going to be true even if the patient is intubated. So you want to coordinate your 90 compressions and 30 breaths per minute, totaling 120 events per minute, which essentially has one event going on every half a second for every minute. It is very high paced and very, very fast. So it requires a lot of concentration and a lot of focused effort. Reassess the pulse after about a minute of well-coordinated chest compressions and ventilations, but we still want to try to minimize the number of pauses in compressions. If the pulse rate is above 60, stop chest compressions and then continue the ventilation at 40 to 60 breaths per minute and recheck the pulse after 30 seconds to see if it's maintaining above 60 and hopefully climbing. When it gets over 100, gradually begin to reduce the rate and decrease the amount of positive pressure ventilations that you're providing. Obtain vascular access. We're going to need to have vascular access if we're going to have to administer fluids to support circulation, or if we're going to need to give any kind of medications or therapeutic drugs. The umbilical vein can actually be assessed using an umbilical vein line, but we typically don't have those available on the ambulance, so an IO may be the most viable option for you. In the pre-hospital setting, of course, as I mentioned, IV or IO is going to be more commonly used. The ability to use an IO device in a newborn is going to depend on policy, of course, training, and the availability of that equipment. Most places have these. Remember, though, that the more preterm or smaller size the baby, the more difficult that's going to be. Of course, consult with medical control to determine if an IO is a viable option, and which in most places it is. It's typically written into the protocol. Medications are typically not necessary in newborn resuscitations, as effective ventilatory support is typically sufficient to get things on the right track. However, if we do have to give medications, remember the dosages are determined by the newborn's weight. A full-term newborn typically weighs around 6.5 to 9 pounds and is about 20 inches long. A 28-week gestation newborn generally weighs around 2.5 pounds and is about 14 3/4 inches long. In these cases, having a Broslow's style of tape to be able to kind of make a determination of the newborn's weight, because they're pretty accurate, will be essential in making sure that you get drug dosages done correctly. But realize the primary goal in this is going to be making sure that we have really good and effective ventilatory support so that it's not hypoxia that's driving the low heart rate and the other conditions that may be showing up. Once we've got the newborn stabilized, we're going to transport them to the nearest facility so that they can get the care that they need. Of course, reach out to that facility and make sure that they're prepared for that and they can handle that newborn that's coming in. Keep the family informed about the current and upcoming care plans. Avoid providing specific survival statistics because it's really too early to know what's going on with this little one yet. If you don't know the answer to their questions, offer to connect them to someone that might be able to answer those questions, more comprehensively. Monitor the newborn during transport and regularly assess for any changes in condition. Make sure that you keep a close eye on their thermal regulation, monitor and help them maintain the proper temperature, not just keep them hot. Make sure we're keeping the right temperature with them. Keep an eye on the respiratory effort, keep the airway open, watch the skin color, and keep a close eye on the pulse rate, because it's a window to what's going on with their breathing typically. Advances in newborn care techniques have helped to reduce a lot of the mortality issues that we've seen in the past. Critically ill newborns may need to be transferred to a regional center for specialized treatment. So there may be times when your partner, your ambulance may be called in to transport a high-risk newborn. And transporting these high-risk newborns is going to involve several steps. The physician and the referring facility are going to kind of work out the details of the transport or the transfer. The mode of transportation is selected based on distance and availability as well as weather conditions. So a lot of things are going to come into play. Not altogether different than what we typically see in those urgent or emergent transports with, adult people. But be aware that these newborns oftentimes are going to require some more specialized mobile equipment in order for them to be transported safely and effectively. Oftentimes they'll send a trained neonatal ICU nurse, sometimes a respiratory therapist, and of course they may even utilize a paramedic with some highly specialized neonatal intensive care experiences. And in some instances, there may be a physician present. We're going to need a ventilatory and oxygen supporting units, probably an incubator. While stabilizing the newborn, the team is going to gather key information such as a copy of the mother and newborn's charts and any radiographic studies of the newborn that may be available. So there's going to be a lot going on during that transport process or the lead up to that. Apnea is kind of one of those things that is fairly common in newborns that are in those babies that are born before 32 weeks of gestation. Fortunately for us, in the post-delivery phase, it's rarely seen in the first 24 hours after birth, but that doesn't mean that we might not get a call to a residence where this is happening. Of course, this apnea is defined as a respiratory pause lasting 20 seconds or more. It can lead to hypoxia and ultimately bradycardia because of the hypoxia. Apnea often follows hypoxia and hypothermia, so the two are kind of closely linked. There are some other causes that can cause this as well. There's some other things that we need to discuss, such as maternal or infant opioid exposure, airway or respiratory muscle weaknesses, septicemia, difficult long labor, gastroesophageal reflux can lead to this as well. And then there's some central nervous system abnormalities that might include seizures and some other metabolic disorders. The pathophysiology for this is going to vary depending on what the underlying cause is. Newborns require respiratory support to reduce the risk of hypoxic brain damage and or organ damage. So it's essential that we provide respiratory support over everything else. And you're going to hear this as being the reoccurring theme throughout this chapter, as well as chapter 44, the next chapter. We're going to talk a lot about reversing hypoxia as the primary thing that we're going to do. It's going to be the first step in our resuscitative processes. We're going to hold back a little bit on those fancy medications that we can give, primarily focusing on getting them breathing well. Of course, assessment's going to include a careful history to help kind of identify some of those risk factors, a good physical exam looking at neurological signs, and then of course looking for signs and symptoms of infection. Then we might want to try to differentiate, or as best we can differentiate between primary and secondary apnea. Primary apnea occurs after a short period of hypoxia followed by rapid breathing then apnea, and then bradycardia. Drying, if this happens right after birth, drying and stimulating the newborn may start the breathing and improve the pulse rate, so it may kind of fix everything. Drying and stimulation seems to be the key here, right? If that hypoxia persists during primary apnea, the newborn will gasp and then enter the secondary phase. When they get to this point, we're going to have to provide positive pressure ventilation with the BVM in order to kind of begin the correcting of this or to be able to treat this. As I've mentioned before, bradycardia is most often caused by hypoxia. That's not a 100% absolute, but hypoxia will cause bradycardia in newborns and infants. It typically responds to effective positive pressure ventilation, so that's the good news. We can ventilate them out of the bradycardia. However, we need to realize that it may not be the only cause. Some other things that can cause bradycardia can be hypovolemia, a pneumothorax, head injuries, even maternal drug use, acidosis. If we've done prolonged suctioning attempts, we can cause this. And then, of course, overstimulation of the vagus nerve by a poorly secured ET tube or orogastric tube can cause this as well. So there's multiple causes of this, but the number one cause is going to be hypoxia, or it's going to be hypoxia related. So a heart rate is assessed by listening to, auscultating the heart, or by palpating the base of the umbilical cord. If the heart rate is less than 100, provide positive pressure ventilation. Assess the airway patency. If the heart rate is less than 60 though, and there has been 30 seconds of positive pressure ventilation, we need to begin chest compressions because there may be something else more significant going on. If it's still less than 60 beats per minute after 30 seconds of ventilation and chest compressions, then we can look at pharmaceutical interventions such as epinephrine, as well as placing an ET tube and establishing vascular access, either IV or IO. After 1 minute of administering epinephrine, check the pulse, ensure that the ET tube is not dislodged, and ensure that chest compressions are being performed properly and adequately. Focus on maintaining normothermia. Realize that making sure that the newborn is normothermic can have an impact on the heart rate as well, and it can cause bradycardia as well. Transport the patient to a facility equipped to handle a high-risk neonate. So that's more than likely not going to be local unless you're transporting patients in a large metropolitan area. And even at that, not every hospital in a large metropolitan area can handle a high-risk neonate. So make sure you transport them to the right place. Suspect metabolic acidosis if bradycardia persists after we've ventilated, done chest compressions, and expanded the volume inside their little systems. We might want to start to suspect that there may be some metabolic issues going on here as well. In this case, we want to consider administering a bolus of normal saline to aid in improved perfusion and to help clear the acid. The best treatment is to identify and correct the underlying cause of the acidosis. Oftentimes, it's respiratory related, but if it's metabolic, it could be something else interfering with that. So, pneumothorax is definitely possible in a newborn and in one that has just been born. This can occur if the infant inhales meconium right at birth, if the lung is weakened by infection, or if positive pressure ventilation is provided too aggressively. Signs of significant pneumothorax are going to include severe respiratory distress that doesn't improve with positive pressure ventilation, decreased breath sounds on one side, and a shift in heart tones if the pneumothorax is on the left side. So we'll see those heart tones kind of shift over to the right if the pneumothorax is on the left side. Clean the area with alcohol around the second intercostal space in the midclavicular line to do a chest decompression. And then, of course, you're going to need the following things handy. A 22 gauge butterfly needle with an extension tubing and a 3-way stopcock, as well as a 20 ml syringe. Palpate the upper edge of the second rib and insert the needle above the upper edge of the second rib. A second provider should pull back the syringe while the needle is inserted, slowly advancing the needle until it begins to remove air. Then you're going to hold your spot. Once it fills with air, turn the stopcock off to the newborn, push the air out of the syringe, reattach the syringe, open the stopcock, and then continue withdrawing air. And then once no more air can be withdrawn from that, we're going to go ahead and remove that needle. If there is symptomatic ongoing air leak, insert a 22 gauge angiocatheter in a similar location. So now we're going to put an IV catheter in there. The tubing can then be taped to the chest wall and briefly occluded. Place the tubing in a small bottle of sterile water and release the occlusion. This relieves the pressure building up until the patient can be transported. During transport, of course, monitor for a reaccumulation of air into that pleural space and relieve it as necessary along the way. A small percentage of babies born with meconium staining and meconium stained amniotic fluid may develop meconium aspiration syndrome, which carries a high risk of mortality and morbidity. This is more common in post-term newborns, newborns that are small for their gestational age, and newborns who have been stressed before or during the delivery process. If newborns pass a stool before birth, they may inhale the meconium-stained amniotic fluid. The airway may become blocked, leading to hypoxia, which can lead to atelectasis, persistent pulmonary hypertension, and aspiration pneumonitis. So, meconium aspiration may cause a delayed drop in pulmonary vascular resistance, leading to right to left shunt across the foramen ovale, or a patent ductus areolus, a persistent pulmonary hypertension of the newborn. So what's going to happen is if they can't get that pressure that they need inside of the lungs in a way that's going to create enough pressure, it's not going to close those shunts and those ducts in the heart that's going to start using the lungs as a means of obtaining oxygen. So things aren't going to close off properly, and it's going to lead to other problems. So what we can do to decrease the risk of that pulmonary hypertension is make sure we've got a good clean airway, keep the baby warm, minimize stimulation in these, and administer supplemental oxygen as needed. If meconium aspiration occurs, we need to monitor it closely for signs of deterioration. So assess the newborn's activity level. If they're crying vigorously, we're going to use our standard interventions. If they're depressed, start positive pressure ventilation. If that's not effective, we're going to go ahead and intubate and suction that baby to try to remove any obstructions that may be present. If they don't respond well to the care outlined in that neonatal resuscitation algorithm, suspect that there is some form of airway occlusion or possibly even a pneumothorax. What we want to do is continue to minimize hypothermia and reassess them frequently while we're running down those leads of trying to figure out what is not working right and what we can correct. Sometimes these little ones will be born with a bit of a low blood volume. Fluid resuscitation may be needed and if these newborns have a significant depletion, and these can be caused by things like abruptio placentae. If it's a twin birth, there may be some twin-to-twin transfusion that's happened. One's got a little too much fluid, the other one's got not enough. Even placenta previa can cause this, as well as septic shock, which is entirely possible in the newborns. Signs of hypovolemia are going to include, of course, poor skin color, persistent low pulse rate, a weak pulse, and no improvement in circulatory status despite the normal efforts of positive pressure ventilation and chest compressions. So we want to consider administering a fluid bolus with these little ones, but realize that multiple boluses may need to be administered if the patient's response is inadequate. Also remember that these fluid boluses that we're going to administer are just not a random amount of fluid that we're going to pour into them. It's going to be a weight-based, formula that we're going to administer to them, over a period of time. So it's not just, open the stopcock and just pour the water to them. We want to make sure that we do that in the proper way. Okay, so that's part one. In part two, we're going to get into a few more of those neonatal conditions that we could possibly run into. Realize though, when we're talking about these neonatal conditions, we could be talking about a newborn that is actually that we maybe didn't assist with the birth on, but maybe at home or something like that. So it can easily get convoluted into thinking that every single one of these is going to be a newborn that you've assisted in the birth of. That's not always necessarily true. It could be a newborn that's been sent home, everything seemed fine, and then things start to go bad. So keep that in mind, always kind of think that way. And I will see you back in part two of neonatal emergencies.